Good afternoon, and thank you, Adriana, for your kind introduction. I'm going to first start, and just to put the perspective, we're going to talk about insulin resistance really as a cause of obesity-related cardiovascular disease. If you were to look across United States and we look at whether obesity is a problem with a BMI over 30 versus less than 30, they're about half and half. Half of the people who have insulin resistance and diabetes are on the obese side, and half are actually on the thin side. So really, although obesity seems to be a risk factor for cardiovascular disease, it happens also that you don't have to be obese to also have, diabetes. And if you were to, of course, today we're going to focus more on the morbid obesity side, which is a major problem. It's about obesity per se across the world. It's about 1 billion people. Diabetes across the world, it's about 500 million. But if you were to think in perspective as an evolution, really, it starts as a metabolic syndrome. A metabolic syndrome is defined that 3 out of 5 of these risk factors present. As of 2009, it turns out about 88% of us are actually metabolic unhealthy, and less than 12% actually are metabolic healthy. So it doesn't matter how you define metabolic syndrome, in which country you are, all they all have in common is actually insulin resistance. And so indeed, morbid obesity per se, it's a risk factor for cancer, cardiovascular disease, Alzheimer's disease. It's an average 2.5 to 3-fold risk for any of those conditions. But if we were to look in both thin and obese, people, insulin really and insulin resistance here is seen as a continuum between hyperinsulinemia, insulin resistance, prediabetes, type 2 diabetes. You have 12-fold risk for cancer, 6-fold for cardiovascular death, and 5-fold risk for Alzheimer's. So what this can seem to be in common for everybody's got a disease is actually insulin resistance, which is the true underlying risk factors. And, some of us are prone to gain a lot of weight and then we'll have obesity, but some of that could be what we call thin outside, fat inside. We tend to get first fatty liver and fat inside the liver. But either way, the common denominator is insulin resistance. And the fact that insulin resistance has been a very strong risk factor of cardiovascular disease has been for a long time. So here is a paper from New England Journal that shows that if you were to look at insulin, elevated plasma insulin percent as a predictor of heart attacks, it's actually, if your insulin is below 12, then your LDL or HDL are not really, or triglycerides are not very good predictor of cardiovascular disease. But if your insulin is higher than 12, then suddenly all the other risk factors become extremely important. So insulin resistance basically is like a sensitizer for all the other risk factors to actually make us prone to have cardiovascular disease. And this was actually set forward a long time ago by Dr. Jerry Raven, who was an endocrinologist at Stanford. And in 1988, he actually surprised the whole cardiovascular world, stating that really it's not the LDL per se, there's a risk factor for cardiovascular disease, actually prediabetes, diabetes, and insulin resistance, and shown that now we know that actually about in patients who are on maximum therapy with high intensity statins and PCSK9 inhibitors, and then we target that LDL at 30 to 50 milligrams per deciliter, there is still a 67% residual risk factor for cardiovascular disease that's associated actually with insulin resistance. And for those, the predictor, actually the highest predictor of heart attack is actually the triglycerides to HDL ratio, and which tries to be a surrogate for small, dense, oxidized LDL. So what is insulin resistance? Well, this is a normal plasma insulin level. We eat, insulin goes up, 2 hours later, it goes back down to normal. And you can do that 4 or 5 times a day. That's a normal metabolic state. Insulin resistance, we start to have elevated plasma level that even after prolonged fasting is still going to be elevated. And eventually it leads to insulin resistance. And then eventually after 10, 20 years of this, we get what we call, diabetes. So big difference between one type of insulin production versus the other. Why? Because insulin is not just a hormone that controls glucose. It's also a hormone that controls growth. We absolutely have, it's essential in the fetal life, it's essential at puberty, it's essential if someone is pregnant as a growth factor, but it's actually deleterious if you have prolonged insulin activation as a growth factor in somebody with cardiovascular disease. And this is how it looks like. Basically, a prolonged activated fasting plasma insulin, it actually switches its effect from glucose handling hormone to more of a growth factor handling hormone. And if it also makes us to, it contributes to accumulation of fat. It helps us retain sodium and water in the kidney. It activates actually the sodium hydrogen exchanger that makes us retain sodium, water, and contributes to hypertension and diabetes progression. But also as a growth factor in the atherosclerotic plaque, contributes to progression of coronary disease and also the development and progression of cancer. And more recently, actually, insulin resistance has been associated also with brain disorders. I'm talking about food addiction, ADHD, dementia, and depression. So this, of course, we don't measure it as all these effects occur about 20 years before the hemoglobin A1C starts to go up. All right, this happens for 10, 20, 30 years. We actually know that glucose per se elevation does not correlate with actually more comorbid disease. What it matters is the duration for which we've been exposed to all this time to hyperinsulinemia. So what causes the hyperinsulinemia? Well, the number one actually cause is fatty liver. So fatty liver, or now it's renamed metabolic associated fatty liver disease by the hepatologists. It's highly prevalent in this country. It's about 45% of adults and about 25% of children. Now, I want to remind you that until 1990, children never used to have fatty liver. Until 1990, for those who been to medical school younger, earlier age, fatty liver used to be a condition only for alcoholics or somebody with viral hepatitis. As a child, to get fatty liver, they don't drink alcohol. It's clear something else is causing it. And once you have fatty liver, your risk of actually type 2 diabetes is 3.5-fold higher. So fatty liver always comes with basically diabetes. It's a matter of time, okay? And we have ways. How do you diagnose fatty liver? We have ways how to diagnose. You have, you can look at triglycerides to AGH ratio as a surrogate, your alkaline ALT elevation, you can have elevated fasting insulin, hemoglobin A1C, uric acid. But at the end of the day, it's a simple question. Do you want to know if you have fatty liver? Just ask yourself this question and give the answer. And if you do have a sweet tooth, you do have fatty liver. The rest is just a matter of time. In particular, when you're no longer 20 and protected by the ability to grow naturally. So, and if we were to look at why is that important to know if you have fatty liver or if you have insulin resistance? Well, from a cardiologist's perspective, right now we have, what really causes heart attack is this small dense LDL, which is the oxidized version of the LDL. And how do we get that? There are three different particles that they're fed into this. One is the classic low density receptor LDL. And there is a buoyant version, which is a large, and then there is the small dense version. And the buoyant version is actually inhibited and is controlled by statins or high intensity statin therapy, PCSK9 inhibitors. But unfortunately, if you target the LDL even to 30 to 50 milligrams per deciliters, you still have it only prevents 20% of the heart attacks in that population. And the reason is because the other two sources of atherogenic LDL particle, one is the lipoprotein little a, which is obvious genetically determined and is probably in charge of about 8 to 20% of the risk of cardiovascular risk. But the single most important 67% of all cardiovascular risk is actually the insulin resistant component of the triglyceride rich particles. So these are the VLDLs that eventually feed into small dense LDL. And those are associated with diabetes and fatty liver. So big question is, how can we affect that? Statins don't impact the VLDLs. Your statins don't impact also lipoprotein little a. For that, you need to just measure it once. If it's elevated, then you know you just have a genetic predisposition. It's good to know about the lipo too, because soon we're going to have ways of actually how to reverse that. We have small interference RNAs against lipoprotein A. They're in clinical trials, and I think in a couple of years, the latest, we're going to have some serious, results about that. But separate, you see, these 2/3, there was so far, there is no drugs that we can affect. And the reason why is because it's all caused by what we eat and how we're going to reverse diabetes that's caused by that. All right. So if I were to say I want to really, in 2024, I want to see how I'm going to assess a cardiovascular risk profile for a patient with blood test, then to me, the most important is to get the lipo level just once, see if it's more than 30 milligrams per deciliter, a triglycerides to HDL ratio, see if it's more than 2.5, and an LDL, see if it's more than 100. Okay, it's not. Really, ApoB is actually more predictive, but for AHA guidelines, they focus on the LDL. And the fact that both fatty liver and diabetes are major problems being recognized by American Heart Association. Having the presence of fatty liver is increases the risk for heart failure 3.5-fold. And really, 2 years ago, finally, American Heart Association recognized that cardiovascular disease is not just a cardiac problem, it's a metabolic problem that starts from the liver. And we need to start working on fixing the fatty liver before we can help with cardiovascular disease. So if I were to put this together in a big perspective, really, cardiovascular disease starts with this hypertension, coronary disease. You can have at the end heart failure, coronary disease, non-alcoholic fatty liver disease, but it starts with metabolic syndrome at a young age. And first, just the fasting insulin is elevated. Eventually, we get insulin resistance. Usually by that stage, it also coincides with fatty liver. And by stage 3 will be you get prediabetes, which is a very unfortunate term. If I were to be a patient and somebody will tell me, oh, you don't have diabetes, you have prediabetes. It's the same like you're pre-dead. You may die or you may not die. We don't know that yet. So I think it's a very unfortunate term that hopefully one day we get rid of, because it doesn't mean anything. As a matter of fact, it's misleading that there is a problem. And then type 2 diabetes, and eventually we declare diabetes really when the disease has been going on for 20 years. Why is a disease? Because insulin is not toxic necessarily through elevation of the glucose, although that is a problem too. It's toxic through the proliferation. That is through non-metabolic impacts of the elevated insulin. So all along, actually, we do have diabetes. We just decide to call it diabetes only at the end stage, an advanced stage. And we decide not to check the plasma insulin, and just because we don't have medicines for that. But I think I'm going to convince you that we do have medicines now, and maybe we can change that. But bottom line is, right around this stage when we get fatty liver, then liver starts to have a lipid profile that's actually specific for diabetic dyslipidemia. And that's triglycerides go up higher than 150 milligrams per deciliter. HDL starts to go down, and your ratio between triglycerides and HDL starts to go up. And that is how you actually, that's a good surrogate for the small dense LDL that ultimately are pro-atherogenic particles. And these are the drugs I was telling you. All the clinical trials so far has been designed. It's only when you already have established coronary disease and cardiovascular disease, really the prevention type. And I'm going to try to convince you that a lot of it, all this is sensitive to diet and what we eat, and coincided with us in the last 50 years, switching our diet from whole foods to ultra-processed food. And we'll go over through that. But first, I want to show you that, believe it or not, everything that it's related to human disease starts with mitochondria, which is our biological clock in health and lifespan that really underlies the link between obesity, cardiovascular diseases. So we have known now for at least a couple of decades that if you were to look at the main 9 risk factors that account for 9% of a heart attack, about 8 out of 9 actually are one way or another related to diet. Okay, and one could make a case that even the psychosocial index, somebody stressed and poor, could be related to the diet too. And then if you were to look at on the other side what the oncologists are seeing, they're almost identical, the same risk factors, except for the oncology side, you also have radiation and ultraviolets, and those all have in common basic oxidative stress. So basically, just no human is an island. Really, what we are long-term in terms of risk developing chronic illness is what we put in our mouth. And yes, 10-20% are genetically determined, whether it's mitochondrial DNA or nuclear DNA, but 80% is actually diet and basically exercise and exposure to air pollution. And this is Dr. Dean Jones who developed the concept of exposome, that we're really, our fate depends on our interactions of actually ourselves with the environment. And I would like for you to get to know Dr. Douglas Wallace. They're both, Dr. Dean Jones is still at Emory. Dr. Wallace was at Emory for 20 years. Now he's at University of Pennsylvania. He's basically the father and grandfather of mitochondrial research that has shown that actually, if you were to look at the single most important risk factors is actually age for everything. If you look here, the risk of, for example, this is a log scale contribution. Once you're older than 70, your risk factor for any other chronic illness is about 10,000-fold higher. Right now, I'm 55. My risk for cancer compared to when I was 20, it's 100-fold higher, all right? And just age by itself is a major risk factor. The question is, what do aging and chronic diseases have in common? And, cancer is not an acute illness. With rare exceptions, there are some genetic determined ones that you get in childhood, but all of them, they come in as an adult. It's a chronic illness. So what do they have in common? Well, they come together, all right? Once you get old, you also get chronic diseases. And for example, if I were to add prediabetes and diabetes, somebody is older than 65 in this country, it's about 80%. All right, so clear, every single chronic illness cluster with age. So how is it that the age makes us predisposed to get chronic illnesses? And what do they have in common? And there is actually a natural experiment that is done in an unfortunate group of patients with Down syndrome. And if you were to look in patients with Down syndrome, you see, even genetic determined conditions, just like Alzheimer's, amyloid, if it's that genetic, why is it only manifest when you get 70 years old? Okay. And it would be interesting to have an answer to that question. But then we actually have, patients with Down syndrome. On Down syndrome, you have an extra chromosome. They have extra genes there. One of them is actually the copper zinc superoxide dismutase. This is an interesting cytoplasmic enzyme that actually neutralizes superoxide, which is free radical, to hydrogen peroxide. But when it does that, it creates actually hydrogen peroxide, which is the main oxidant signaling. And when it does, it actually increases the oxidative stress. And these kids with Down syndrome, they have 3.5-fold higher risk of actually diabetes, but also the risk of cancer in Down is about 10 to 20-fold. They get ALL, AML. And what's fascinating, dementia that otherwise on a regular person would arrive at age 70, they actually get it about 20 years younger. And then you say, okay, what about amyloid that happens? And indeed, they get amyloid too, but that precedes by 10 years. And then what precedes the amyloid, it turns out, is actually the oxidative stress that starts at 20-30. And while for us, when we take our time to get old, it starts at age 60-70. For them, it starts much younger. And what they seem to have in common is this extra chromosome 21 comes with a mitochondrial inhibitor that doesn't allow their mitochondria to regenerate normally. We get our mitochondria from our mothers, the DNA. They are usually every 2 weeks. We totally renew our mitochondria. But these patients with Down syndrome, they have a mitochondrial biogenesis inhibitor that blocks the transcription factor, and they are unable to renew their mitochondria. They get early life oxidative stress, and they get all the conditions from there. What I'm trying to make a case here is that Down syndrome is actually a mitochondrial disease, and chronic illnesses, chronic diseases, and aging per se, it's a problem with chronic mitochondrial dysfunction. And that's what both American Heart Association or Heart Failure Society experts recognize, that actually heart failure, it's a chronic mitochondrial dysfunction. And if you were to look at the incidence of prediabetes, diabetes, somebody with heart failure, it's about 82%. You almost cannot separate diabetes or insulin resistance from heart failure. And you can start having first heart failure and then eventually they develop diabetes, or the other way around. They are very close together. And, Dr. Wallace actually has shown that a lot of the conditions associated with either heart disease, brain disease, or pancreatic insulin, who depend on the oxidative phosphorylation of very healthy mitochondrial function. And if you have single mitochondrial mutations that can lead to that. And one cannot understand why this happens is because mitochondria are absolutely essential for in our life to move from prokaryotes to eukaryote. We acquire that when we and then once we acquire that, we are able actually to become complex organisms. There was no, you see, bacteria never evolved. They are single cells in population because they don't have mitochondria. We have mitochondria, which allow us to actually move to complex cells, to organs and organisms. They determine our cells because we're able to not only make ATP and become energy independent, but also we have, through the Krebs cycle that works with the electron transport chain, we're able to actually create the substrate from the food that we can grow. And then about 700 million years ago, once through photosynthesis, the oxygen level went up to 20%, we're able actually to, all we need to is to have more micron per cells, and we became mammals and got bigger. But bottom line is, life itself in your eukaryote cell has developed when we acquire mitochondria. Everything that means life and death and chronic illnesses, it actually ends with mitochondria. And here's why. If you look into what's the ultimate way how we create ATP, you have the NADH. Basically, all the food is it extracts electrons under the NADH. The NADH then passes on, splits the electron to use that energy to create this proton pump gradient. Electron then is passed down to eventually to molecular oxygen and creates water. But in the process, this tremendous proton pump gradient allows the ATP synthase to work, create ATP. But having this proton gradient across an impermeable inner membrane creates a charge. That charge in the mitochondria has to be, it's a homeostatic variable. It's minus 170, 200 millivolts. If it gets higher than 200 millivolts, let's say we feed too much substrate, then these electrons, if we give too much food, then electrons will back up, and then we start to create free radicals. Everything has to go backwards. It can't go further down. And then the oxygen is going to be directly reduced by the hydrogen. And the other way around, if we are sedentary and we don't sleep, we don't create the need for ATP to have ADP, then we can also back up this plot. If the proton gradient goes down and we lose this electron, membrane, then actually mitochondria will say, you're no longer good to create, for us to be able to create energy, and it causes apoptosis and cytochrome C release. So everything that means life, the difference between somebody alive and somebody dead is whether this proton gradient is maintained or not. Everything that we eat, everything we breathe, eventually ends up into this particular place. And biology has evolved to, based on our exposure to the environment, but it has constrained that are limited by the chemistry, metabolism, energy flux, and ultimately physics, ability to maintain this proton gradient. So when we study diseases, or we say we're going to study this organ or that organ, we have small different biases approaches from one organ, this piecemeal approach, and then we tell you the risk factors, or what's cardiovascular disease, genetics, diabetes, hypertension, or cholesterol. But in reality, everything depends on this little proton gradient, whether it's maintained or not. Mitochondria is actually one big battery. One big battery that's, if we were to add everything that's produced in our body every day, it's equivalent of one electric bolt in terms of the intensity for how small is the membrane. And we have received our mitochondria from our mother, and the moment we are conceived, imagine that mitochondria are like a big Tesla battery. It's supposed to last for 500,000 miles. And how fast that battery runs through, depending on the risk factors, is how long we live, and also whether we get disease or not. As long as you have enough battery, that battery cannot be recharged, only runs once. Mitochondria divide every 2 weeks. Each time they divide, the new proteins that are produced are a little ever so less perfect than were the original ones when we were conceived. So how long we basically preserve this battery is how long we're going to live. Once we understand how this works, we're going to be able to do something about risk factors and everything else. And Nick Lane said that, who is an evolutionary biochemist at University of London College, says if life is nothing but an electron looking for a place to rest, death is nothing but the electron come to rest. And a battery is discharged, Batteries are like one of those things. You don't know them, you don't miss them until suddenly the battery is gone and you don't know why the remote doesn't work. But that's exactly what it is. So now that I gave you the perspective of that, no, the Krebs cycle really works to produce the substrate, but feeds into the electron transport system. And if we are able to have this nice pass on of electrons from one element to another, then we produce a lot of ATP and we have very few free radicals. But if we are sedentary or if we have oversupply of food, then they start to accumulate and you start to have lots more free radicals. They're what we call leaky from this, create this electron leakage. And then we start to move our mitochondria start to produce oxidative stress. Oxidative stress, then it's a stimulus for proliferation for the cells. And we start to move into this phase of what we call chronic metabolic disease and syndrome. So we can live here, where it says that healthy younger with less oxidative stress, or we can live here. And we can be in this stock for 30, 40, 50 years. But all it means, if God forbid, and I'm going to get some kind of acute illness, all right, then I'm going to have, for example, somebody gets cyanide, you can immediately block your mitochondrial chain and then you stop. But what if you get COVID? So basically the COVID-related ARDS or COVID myocarditis, turns out COVID has a microRNA that targets this mitochondrial transport chain system universally and basically shuts down the whole mitochondrial engine. So those who actually die, unfortunately, from COVID-related ARDS, pneumonitis, or myocarditis is because COVID has targeted their mitochondria at the large scale, and they have no time to regenerate and do their part. And this will happen if you were to, why were you predisposed? Because you were having this metabolic syndrome, insulin resistance, and you're at this stage of advanced mitochondrial dysfunction. But the most common, what really prevents and poisons mitochondria are actually chemicals that we have from our food. Fructose, for example, linoleic acid from vegetable oils, or alcohol. So any chronic ingestion of this, independent of their caloric nature, this has nothing to do with the calorie. They actually interfere with mitochondrial function and shifts our cells from actually burning the calorie, burning our fatty acids and glucose towards actually storing. All right, storage is very important here because the job of the fructose and the linoleic acid from vegetable oils was to tell us winter is coming, you need to store. That's how bears and squirrels, before they go in the winter, they go for the nuts and they go for the fruits and vegetables because it allows them to store and gain a lot of weight right before the winter when they're not going to have similar kind of food intake. So what I was trying to say is mitochondria are the ones who not only allow us to develop in harmony as in higher organs and organisms, but if they are not functional, they actually communicate with each other. They change our phenotype. Turns out they actually can leak mitochondrial DNA that then tells all the cells. You could have just one organ disease, and then it turns out mitochondria, that particular organ from heart failure, will release the mitochondrial DNA, then tells the whole body is sick, and then it starts to create actually disharmony. And in particularly heart failure, you have neuronal activation as a consequence, and the neuronal activation actually causes further insulin resistance and diabetes, and the cycle perpetuates. So if our mitochondria are healthy, then we're doing good. If our mitochondria are not healthy, we're going to have disease. And even if it's just a single organ disease, it's going to spread to all the other organs. So a more integrated view is that what's wrong with our diet is actually the ultra-processed food. And the ultra-processed food is high in fat, but again, not necessarily the saturated fat. Is actually the omega-6 vegetable oils fat. It's it's high in high sugar, particularly the fructose, salt, and low fiber. That means we take the food, fiber is there, is supposed to actually bind the fructose and other, and it's supposed to be food for our bacteria and not allow the fructose to get into our system. And then we have obesogens. They are coming either in the plastic bags that we have, could be in the pesticides, it could be in, various coloring and everything. I don't have time to go into how these are, but they are probably, the obesogens are probably in charge of 20% of chronic diseases. If you want to, you can read this article that I quoted here by Dr. Lustig, who just published a month ago, that goes in excruciating details about each and every potential harmful effect of this. I actually group all this together into food additives. So I call them the FEPs: flavor enhancer, emulsifiers, preservatives, and sweeteners. So that's all this group on top of the other macronutrients are actually part of the ultra-processed food. So here's the deal. Does it matter where the food comes from? Should we eat whole foods? Does it make a difference, or ultra-processed food? How do we know? So here is Dr. Kevin Hall, took 40 healthy humans, basically put them in a hospital, followed them for 2 weeks, and he says they gave them exactly the same food that was either from whole foods or ultra-processed food, but the same macronutrient content. I mean, the same fat, the same percent of proteins, the same percent of carbs, and they all did 45 minutes stationary bike a day. So basically, macronutrients are the same, except one got it from ultra-processed food and cooked, the other one got it from whole foods. So what you notice here, within 2 weeks, the one who are eating ultra-processed food version, they gained 2 pounds. The one who are eating whole foods, they lost 2 pounds. At the end, in 2 weeks, there were 4 pounds difference in average between them, although they had exactly the same percent of fats, carbs, and protein. So this suggests that the source is more important, how it's processed and what the additives you have to that food, than actually the percent of macronutrients per se. Of course, they were allowed to eat ad libitum, so they will allow you eat as much as you want. You have the same exercise. And yes, the ones who are eating the ultra-processed food version, they ate in average 500 calories extra a day. And when you look at their metabolic profile, they were, all the hormones that we know are associated with diabetes, they were increased. They have higher insulin, higher leptin, higher ghrelin. That means they were hungrier if they ate ultra-processed food, and also they had less satiety. Okay, but the most important part is that if they measure also their basal metabolic rate was way higher in the ultra-processed food version versus the whole food version. What does that mean? Our basal metabolic rate predicts how long we live. The lower the basal metabolic rate, that means the longer those mitochondria are going to last and we live the longest. The faster your basal metabolic rate, that means when you're resting in your sleep, then the less you live, the shorter you live. So basically, this suggests if you continue like this, you're going to live 7.8% less than the ones who eat whole foods. Okay, so, and then of course there was so Dr. Kevin Hall concluded, well, there's got to be something specific to ultra-processed food that actually makes us, gain weight, but also eat more. All right. And then this just goes along that theory. And then the opposite experiment was done where humans who were young folks in their 30s, they were placed actually try to restrict their calories 10% for about, and they lost 10% of their body weight for the next 2 years. And then they looked opposite at their metabolic rate. And the weight went down by 10%, their metabolic rate went down, their oxidative stress went down, and also insulin and leptin. In other words, the only way and the most important way how we can live longer and with less chronic disease is not only that we got to eat less, but also we need to eat unprocessed food. And everything else is kind of irrelevant. And that's the only way we know. And I'm going to, for those, and this is a Cochrane review, meta-analysis was published actually last week. Here is ultra-processed food has been associated with higher risk of heart rate mortality. The hazard ratio is here 1.6, type 2 diabetes 1.4, mental disease, chronic mental illness. I'm talking about anxiety, depression, but also serious psychiatric illnesses like schizophrenia or bipolar disease, obesity, sleep disorder, and also fatty liver. Excuse me. Just to have an idea, this odds ratio, if LDL is elevated, the odds ratio is 1.3 that we get cardiovascular disease. Triglycerides elevation over 150, that's an odds ratio of 1.8. So this is in the ballpark, actually more than if your LDL is elevated in terms of risk of dying from just by eating ultra-processed food. And what exactly, everybody knows, okay, from our grandma, don't eat junk food, right? We knew this for 50 years. What else is new? Well, we got sophisticated. What matters is, okay, what are exactly the chemicals in that food? Because you can't say everything is labeled. You're not going to eat. Ultra-processed food is here to stay. How do I identify what can you eat or you cannot eat from what's out there? You cannot always just cook. I mean, bread, we can't cook all the bread we eat. So, so here's, I'm going to give you some clues here. Number one is fructose. Fructose is half of glucose, or half of sugar, right? That is a direct mitochondrial inhibitor. The other one is the trans fat. Trans fat has been banned, so we don't have to worry about it. It's the old margarine that we used to cook the chips with. So we got rid of that. But it turns out we can make trans fat by using heating vegetable oils and frying with it. So you take vegetable oils, if you heat them higher than 300 degrees, and you either make the chips from it, whether it's cookies, chips, or if you make your own French fries at home, it creates trans fat and it creates aldehyde. So you can actually do the same thing in your own dish. Alcohol, everybody knows, but that's, I don't have to, debate that one. And then also these protein bars, well, we call it protein bars, but they're really carb bars. They, with excessive actually branched chain amino acids, can cause that. And then you add these food additives that we're talking about: flavor enhancer, emulsifiers, preservative, and sweeteners. All right, these are actually the main culprits that cause fatty liver and diabetes. These are the 4 elements that we need to watch on. And when you look at, and you say, well, look, here is sugar and vegetable oil consumption in this country since 19th century. All right, you see the correlation with the obesity. Vegetable oils, we used to have 0 up to about 1900, and Crisco introduced the first vegetable oil, and now we are about 80 grams, a day, from 0 to 80 grams a day. And actually it's more than the saturated fat and what comes from the meat. The same with the sugar consumption. We increased from to about 90 grams a day. That's about 4 times more than American Heart Association recommends. So now we have the vegetable oils and the sugar, the suspects that are at the crime scene, but does that mean they are causing the disease? This is association, right? And bottom line is, I'm not gonna, those who want, they can watch. I have an equivalent lecture there, but but what you need to know is that evolutionary, we are actually pre-primed as humans to eat fructose, and to basically, why? Because the fructose that's in the fruit seasonally or in the honey, we used to be only in the summer, actually makes us retain sodium, water, makes us actually store fat, and also it's important for hypoxic conditions. So this is something that we evolutionarily conserve the pathways to be able to survive when we used to have no food in the winter. And we have the same mechanism of survival when it comes to actually omega-6 fatty acids from nuts, seeds, or grains. Unfortunately, what used to be seasonal and only from time to time, now it's a daily thing. So how many times a day do we eat if we're in this country? It's 8 times a day. We eat 3 meals and 5 snacks. And if we were to put together how much is that from ultra-processed food, 62% of all our food, there's 23 comes from that, from which 90% of all added sugar comes from that. So obviously, this is not something that we were designed to be able to deal with. The fructose is actually able to suppress these enzymes that allows us to burn our fats and everything else, called MMP kinase. It also creates this free radical aldehyde called methyl glyoxal that inhibits irreversible that AMP kinase. And basically it tells our liver, I want you to store everything you eat from now on, okay, once you get it in our system. And by itself, it's free radicals too. I don't think, bottom line, it programs acutely. Fructose doesn't release any insulin. It's actually not even seen as a carb or as a sugar. But if you have high increase over 3-6 months, and this has been shown in humans, it's been shown in children, it's the long-term exposure, and it's dose-dependent chronic exposure every day that matters, that causes fatty liver and insulin resistance. So that's important. The second villain that is important is the actual linoleic acid that comes from ideal, in the past, used to be just from grains, seeds, and nuts, all right? And it used to be seasonal. Well, it turns out that linoleic acid derives, we make, in a dose-dependent manner, our own endogenous cannabinoid receptors, okay? The one that marijuana stimulates for pain, but also for food, comes from linoleic acid. And turns out that the more of this linoleic acid, the more of those receptors we have, and the more actually the hungrier we are. And basically in the past, as I mentioned, the source of linoleic acids, which is an essential, otherwise fatty acids used to come from grains, but now they come from vegetable oils. The endocannabinoids that are produced from linoleic acid from actually 2-AGs, 2-arachidonic glycerol. This comes from linoleic acid, and in a dose dependent is boosted up. If we actually stimulate, it stimulates our hypothalamus to want to eat more. So when we put something that has any form of fat, is actually this omega-6 version that makes us want to crave that food, that part of the ice cream. But at the same time, turns out our fat adipose cells have receptors for that, and it stimulates the adipose cells to double inside and want to. So it works both central and also peripheral. And we do have actually a cause-effect clinical study that showed that these receptors are very important for us in obesity. Anybody's ever heard of Raymond Unbound? You know, in 2006, the whole cardiology world was very excited. Raymond Unbound was Ozempic before Ozempic. In 2006, it's actually the only specific cannabinoid 1 receptor antagonist that blocks the receptors in the hypothalamus for food. So actually suppresses your appetite just like we do, but also works on periphery by causing lipolysis. In 2006, it turns out that in 6 months, you lose 10% of your body weight. It was extremely effective. Basically, you just stop eating. And of course, cardiologists are very excited because suddenly obesity went down, you know, insulin resistance went down, and we got very excited. Finally, not only we have a drug for obesity, but also we have a drug of preventing diabetes in somebody with obesity. And the catch is that by 2009, 3 years later, turns out that the same opioid receptor that we use for the brain to eat, we also used to have our reward and pleasure system. So people started to be depressed and have suicidal ideation, and they had to take it off the market. So it's okay not to eat, but it's not okay to be depressed and hurt from that, okay? So then they had to stop this, but bottom line, improves cause effect that this omega-6 and the way we create those endogenous opioids are very important to stimulate us to eat, but also to have obesity. And this polyunsaturated fatty acids are essential. I mean, we have 3 kinds. We have the 1 double bond version, which is the omega-9. We have 2 double bonds, which is omega-6. And then we have 3 to 6 double bonds. These are the EPA and DHA, are important for the brain and for cardiovascular system. They are essential. Our body doesn't make them. You have to eat them from outside, right? The catch is this. You only need about 2% of all fats from the body to get the minimal requirement. And the same, what makes them essential, this presence of the double bonds makes them also very sensitive to oxygen and heat. So if you have too much in your diet, and if you heat them up, look what happens. If you start to actually fry, you know, let's say you do some French fries, and you start to measure the oxidation level in those French fries, then suddenly we start to obtain these alkanols, or where it's aldehyde, basically it's rancid versions of oxidized polyunsaturated fatty acids. And even if olive oil seems to only produce half of this, it's half as bad. Why? Because it has predominant omega-9s, but you still have 15% omega-6 even in olive oil. So, you know, there is no safe vegetable oil that we think about. If we actually, when we measure it, they're all absolutely disaster when we actually go and we measure it. Okay, it's oxidized. There's nothing healthy. The only thing is different is the smell. Okay, the way they manage how to figure that out. So, because the normal needs of this polyunsaturated fatty acids is about 2% of calories a day. That will be equivalent. Basically, you need 1 nut. That's it. That's all you need. You're not going to ever be deficient of this. It's in everywhere. It's in, you know, wheat has 60% omega-6. You know, every nut you can imagine, you don't have to worry about it. And the problem is that American Heart Association recommends we should eat 5 to 10% of all our fat should be kind of vegetable oil fat, which I get it. The problem is that why? So we don't eat the saturated fat, right? Because, you know, meat is bad for you, butter is bad for you. Well, the catch is we are currently at 24% a day. We're way beyond that. And then the half-life of this omega-6 in our fat is 2 years. So I still have in my fat, not that I ate 2 years ago, okay? And this is a cumulative impact. And the problem is that actually when we measure it, we have 3 times higher than in the 70s, now in the 2000 linoleic acid content. So we are anything but potentially linoleic acid deficient, you know? And why is that? Because if you look at the fatty liver, the hepatologist, while the cardiologists are recommend you got to eat more and more of these vegetable oils, when you look at the hepatologist and study, if I were to switch my specialty, and we do liver biopsy to predict liver cirrhosis, the worst possible negative predictive factor is the oxidized linoleic acid, what we call oxlam, this 13-HODY, into the liver biopsy. In other words, the single most important cause of liver cirrhosis and fatty liver is the oxidized linoleic acid. There's nothing wrong with linoleic acid per se. The problem if it's oxidized. So who gets it oxidized? Well, if you have prediabetes, diabetes, mitochondrial dysfunction, like I say, you go high increased oxidative stress, and somebody who is prone to storage. All right. So we got a problem here. So when you look at the biopsy, actually, the risk of end-stage liver disease and cirrhosis is 9 to 30-fold. This is a Cleveland Clinic study. This is human liver samples. Okay, this is not a mouse study. And then here's the mouse study too. They just vary just the linoleic acid. Remember I told you we're at about 10, 12%. I mean, we're at 24% intake. This is mice only 1% versus 8% in their diet. Immediately they get obesity, nothing else but just this linoleic acid, a little bit increased, 1 versus 8%. They get obesity, they get triglycerides are up, just like in humans, high cholesterol, insulin resistance, fatty liver, you see these white bubbles here, inflammation and fibrosis. And that's 8% for mouse, not 24% that we eat today in humans, okay? So, and if you think it's hard to get that, here is an example. I have chicken, I have potato that I'm baking, and I have salmon that I'm gonna bake. We're gonna compare the content baked versus fried. Look at the numbers. If it's cooked at 300 degrees, if it's baked, the chicken only has 0.4 grams of fat, and it's mostly saturated fat. Well, what if we fry it? Well, we get all that oil actually goes inside the meat. You can't take it out and say, oh, I'm just gonna bounty it and it goes away. No, no, no. It's inside the meat. You go from 0.4 to 14 grams. So I know we say, well, saturated fat is bad for you, but it's 90% is longer fat to saturated fat. That's vegetable oil they got in it. And this oxidized omega-6. What about baked potato? What if we make French fries? Well, it goes up to the 20 grams. Notice the difference. What about the fish? Everything was ever good with fish. Once you fry it, you're done with the health. It's oxidized in 20. Like they say, we got bigger fish to fry. Okay. All right. So if you thought you're eating anything healthy with that fried fish, I mean, it's amazing tasty, and doesn't mean I never eat it. It's just, I can tell you, your liver is going to take a while to clean that up. Okay. 50 to 100-fold more fat from vegetable oil is not saturated fat. That is the problem, because we're not designed to have this. And I'm not even talking if you go and eat a commercial burger somewhere. I'm not going to say names. But believe it or not, none of that is all those are low, very low disease compared to what you get from just one bag of potato chips. Okay. All right. This is whatever I showed you. You think you're worried about making French fries at home? Never mind. Never mind that. All you need is a bag of potato chips. The damage 10 times worse. Why? Do you know how they make the chips? The crispy, to be crispy so you like it. It doesn't matter if they bake it or not. It's the same crap. They have to add the vegetable oil, and they have to heat it at 400 degrees. Everything is oxidized. Everything is completely. And it's not only that, the amount is huge. Look at this, your bag of 400, equivalent of 15 potatoes and one bag of chips. You got 120 grams of fat, of course. But the worst part that is not documented, is documented by scientists who measure it, is actually the presence also of other byproducts that come from that omega-6 linoleic acid called acrylamide and aldehydes. And why is that important? Here is the deal. Does anybody know how smoking causes lung cancer? Anybody knows? We actually know that. Okay. Here's how it causes. Aldehyde. All right. You actually, the same aldehydes that we showed it's incriminating to cause lung cancer from smoking a pack of cigarettes a day is the same ones that are produced by just frying using vegetable oil or heating up anything using vegetable oils with a temperature higher than 325 degrees. Okay. Here's the equivalent. There are actually some crazy scientists like me who actually start to measure those things. This is not me, it's somebody else, but I know where to look and who has done it in London. And they measure actually how much of this acrylamide aldehydes is produced by a small portion of French fries. I didn't say which company, it doesn't matter. I'm talking about small size, not big size, 150 grams. And it's equivalent of, anybody guess? Equivalent to smoking a pack of cigarettes a day in aldehydes. Just this is the small portion, not the medium, not the big. Okay? All right. Now, we do have problems if you smoke in my face for a pack a day, but we don't have any problem with this, although this is way more damaging, but it's socially accepted. So keep that in mind. That's where the problem comes from. And if there's nothing else that you got out of this lecture, I want you to remember that. This is the single most important slide of the day. All right. And then it's not only that, but this oxidized version, also contributes to oxidation of the LDL. If you were to look at, the bad LDL, which is the oxidized LDL, what is oxidized? What is oxidized is actually the apoprotein B100. That's the receptor for the LDL. So the liver knows to take it back from the circulation, right? That's how we lower the cholesterol. We use statins that lower upregulate the LDL receptor, then the LDL receptor sees the LDL, ApoB100 gets it back into and clears it from circulation. But if your ApoB100 is glycated, which the glycation occurs in response to fructose, glucose, and this methyl glyoxide, all right? Basically, glycation means it's oxidized by hydrogen peroxide from these compounds. We call this age, advanced glycation end products. Hemoglobin 1C, it's an example of age. Your fructose and glucose attacks the hemoglobin, causes hemoglobin 1C, and it's an oxidized version of hemoglobin 1C, hemoglobin. And it's the same with this. Once you oxidize your ApoB100, it no longer recognizes the LDL receptor. So what they do, they keep hanging around in circulation forever until eventually it gets under the endothelial cells, all right? That's one version. And the other oxidized version of the LDL is actually the cholesterol ester. You see, the cholesterol ester is a cholesterol that binds to a fatty acids. The number one fatty acid is 95% of all these cholesterol excites are linoleic acid. So linoleic acid is also substrate for bad cholesterol, in case you didn't know where it's coming from. 95% is that, and it does the same thing, all right? Now, it doesn't mean that if you ate a little French fries, everything is going to end up there, but everything is cumulative. And of course, we have defense mechanisms to try to protect us. There are deglycation enzymes, they're trying, but it all depends how much you put in and how much your defense is out, okay? But that's part of it. All right, and of course, if I were to, you can blame it all on your turkey or on your fried chicken they cook at home. That's the least of your problem. Please pay attention to these guys. Consumption of fried food has been associated with heart failure in humans. We have multiple studies showing that, including the inter-heart study I was telling you. And how you process the food is what matters. And how did they work? Work just like alcohol. Fructose, omega-6 fatty acids, they're processed the same like alcohol. These are some equivalence doses that I tell you there. When you think your child gets a glass of orange juice, no, they're getting a shot of bourbon from liver perspective. It's the same. It's processed exactly the same way. It's not a joke. Yeah, I know it sounds, but it's true. And then turns out all these three, villains, which is the omega-6 from vegetable oils, the fructose from sugar, and the alcohol, they all work through the same mechanism. They produce one or another, these three aldehydes. All right, sorry, I don't know my pictures here. All right, so it's just they have different names for it. It's methyl glyoxide for the fructose, acetaldehyde, which we know for alcohol, and oxidative linoleic, acid for the. But they all work to the same by creating oxidative stress. And of course, our cells are fighting. All right, you want to see Cheetos? Who doesn't like Cheetos? Come on, it's in particular now they have, I don't know what's flaming hot version, but Cheetos are, you can't resist them, right? But here's how you read what's wrong on the label, okay? Because they're actually vegetarian. If you think about it, they're vegan. So you see on the fat part, you see it says vegetable oil. Why is that important? Because if you were to look also was not on the label. So you have total fat, it's 11 grams. But you subtract the saturated fat is 1.5 grams. Why is it that I don't care about saturated fat? Because you can heat it up, it doesn't do anything, it doesn't get oxidized. It's not Okay, it's just a little saturated fat. That doesn't damage anything. It's used to be burned. It's what matters is the polyunsaturated fat that's oxidizable. So that would be, if you subtract that, you get about 10.5 grams of vegetable oils. That's about 2.5 teaspoons of vegetable oils that you have in that little, whatever, 21 pieces of serving. And then you look at your total carbs and say, well, but there's no sugar, no added sugar. That's true. So 15 grams divided by 4 grams, that's equivalent of 4 teaspoons of carbs. But what kind of carbs are these? Those are aged carbs. They're glycated, oxidized carbs. They're going to hit on your proteins and age your proteins. There's nothing else. Why? Because they be heated up under dry condition at 400 degrees. That's why they're poisonous. Okay. So this is an extremely taste. And then you have the others that I don't even bother to read anymore. I call them FEPs, flavor enhancers, emulsifiers, preservative sweeteners. And that's about 20% of the damage. 80% of the damage is your polyunsaturated fatty acids and the carbs that be heated up. 20% is the other stuff. And basically at the end, this is how we define ultra-processed food. Contains additives, adds sugar or fructose, age, frying vegetable oils, and inflammation, oxidize LDL. And now you know why what used to be in the 70s, diabetes used to be an old people disease. You had 99% of all diabetes was somebody older than 65. Less than 0.1% in somebody younger than 65. Well, where are we now? 60% in people younger than 65. We move way younger. And we got also fatty liver, both in kids and adults. And that's why, because we have increased this, particularly kids, teenager, up to 70% ultra-processed food. All right. And basically our children and young adults are aging fast and miserable. Why is that important? Because I showed you the evolution of coronary disease, 30 years it takes. Well, those 30 years start now at age 2, 3, 4, 5, not at age 25, 30 like it used to be. So I see my new patient at age 60, 65. Now we're getting heart attacks younger and younger, diabetes type 2 younger and younger, cancer younger and younger. And I can tell you my brother is way busier than I am. Actually, it's exactly the same age, so we got a problem. All right, I promise you I'll talk about Ozempic, just 5 minutes of Ozempic. I hope it was something interesting that was not Ozempic related. But bottom line is, I was telling you that this ultra-processed food changes our mitochondria to function under high oxidative stress. Those free radicals changing the phenotype of the cell. We have different cells. We think we have cardiac myocytes, smooth muscle. No, they're completely different. The same with the brain cells. So here's how we regulate our food intake. We have the homeostatic center, which is the hypothalamus. Then we have the pleasure center that all animals have here in the back. Limbic system is what makes us to be addicted to anything and like something. And then we have the executive center. Only us, we have it, which is the prefrontal cortex. So as you can imagine, it's always a fight between the executive center. Is this right or wrong versus the pleasure center or the homeostatic? Well, if somebody is normal and healthy, metabolically healthy, sugar, eating glucose and fructose has actually no impact on those centers. If there's anything, glucose stimulates a little bit your executive center. But if you have insulin resistance and you have morbid obesity, then fructose, that's exactly opposite. It blocks your executive center. Basically, you eat and you don't know you're eating. You're actually losing your mind. It stimulates, it's addictive. It makes you want more. And it stimulates your homeostatic center. You want more and more and more. I mean, perfect example, if you have a big pizza, you can eat a slice and you drink a soda, then you wait for an hour, you watch more TV, you're hungry again. And you keep going and you never know that you're actually full. And it pulls and bypasses the usual way of us knowing when to stop eating. And so that's a major problem. And then what happens is we live in a society where we're stressed out right now, and we release cortisol. And if you release cortisol, cortisol does exactly the same thing. Stimulates your amygdala, release dopamine, and it makes you want to eat more. The good news now, we have a drug that actually we can work on the homeostatic center. This GLP-1 receptor agonist, which is semaglutide or tirzepatide, also called Ozempic versus Mounjaro. And if you basically directly blocks this homeostatic center, bypassing the other stuff. So, and it works also, it has multiple mechanisms, but the most important one is this. The other one is slow downs. It causes reduce of gastric emptying and slow down the metabolism. So now the big question is, can we treat with Ozempic or semaglutide try to lose 10% of the body weight and in the same time prevent cardiovascular disease. All right. And what really matters is actually not the fat that's in the subcutaneous tissue. It matters the fat that's in the liver or the visceral fat. That is the one that actually causes diabetes. And if somebody is, because for example, if this year if we look with the MRI by the liver, is you can have this morbid obesity, this particular patient, similar with the other, except that this one does not have any fat in the liver. It's metabolic healthy obese. It's fine. Some people are like that. But the other ones are, this one has actually liver cirrhosis already, 20% of the fat being with fat. And then this one is a thin outside fat inside. It's mostly visceral fat and liver, but no subcutaneous fat. So let's say if I need to, how much weight do I need to lose in order to be able to impact my fatty liver? And the rule of thumb is about 10% of the body weight. That's about 22 pounds. So if you, and this study was done actually in the past, it showed that if you lose at least 10% of your body weight fat, you actually can reverse diabetes and fatty liver. All right, so the study that was designed is called the SELECT trial that was published in October. 40 years, 17,000 patients, prior heart attack. So this is established coronary disease, secondary prevention, morbid obesity with a BMI over 30. They either had heart attack or they had, peripheral vascular disease, strokes. The requirement was they don't have diabetes, so they could not be enrolled in the study. They had full-blown type 2 diabetes. But if they had pre-diabetes, it was okay. As a matter of fact, 2/3 of them did have pre-diabetes as defined as a hemoglobin A1C between 5.7 and 6.4, but not 6.5, okay? And then they were on decent therapy. These were with the target LDL in average of 78, and then the study was actually overwhelming positive. After 4 years follow-up, if you look at the absolute MACE, what we call multiple adverse cardiac events reduction from 8% to 6.5%, 19% reduction. The mortality was not changed, but was not designed for that. If you were to compare what's the impact compared to high intensity statin, when we try to target the LDL below 50, it's almost similar impact. It's actually maybe superior a little bit. So this is as potent as actually statin, high intensity statin therapy per se. But the single most important that is probably being ignored is mentioned somewhere in the note, and probably all my colleagues are going to just look at, oh, you lost 10% and you also prevent, heart attacks. That's great. Okay, but the most important actually finding was this. Pay attention to this. New onset type 2 diabetes was reduced from 12% to 3%. It literally prevents type 2 diabetes from developing. And the pre-diabetes is reversed in about 60% of the patient. People don't realize, so you try to prevent type 2 diabetes. Metformin is the only drug we have about that. People who are morbid obese and we give them metformin, it helps actually, it takes about, its necessary number 3 is about 20 to 1, all right? This is the most important drug we've ever had to actually not only reverse pre-diabetes, at least in those who are morbid obese, but also prevent development of type 2 diabetes. And this is the main mechanism, probably to me, the most important take-home message, because this proves that the way obesity causes heart attacks or causes cancer is because it's a byproduct. It causes diabetes and pre-diabetes evolution into diabetes. And now we have a drug that actually can prevent that. And that's the most important. I mean, if we were to look at what we call necessary number to treat anything below 10, so you can treat 10 to save 1. It's in heart failure, beta blockers are 9 to 1. I mean, we now treat about 2 out of 3 patients with heart failure, drugs, and we think we're heroes. Okay, these 1.3 you treat 1.3 to save 1, huge impact, and that's why I think is important now. But the most important fact is, if you were to say, okay, what can we draw as a conclusion from this SELECT trial? Well, somebody who's got morbid obesity, has prior coronary disease or peripheral vascular disease. We give them semaglutide or tirzepatide, high dose, to lose 10% of the weight. Then indeed, we reduce coronary disease by 20%. But the main mechanism is, other than blocking your food intake of the brain, is actually the most significant impact is actually prevent pre-diabetes evolution or diabetes, fatty liver, insulin resistance, So I'm going to propose to you that actually from cardiometabolic perspective, all right, not from endocrine, I'm not an endocrinologist. I'm just going to say cardiometabolic perspective. For example, in heart failure, we have stages of progression of heart failure. We have stage A, we have risk factors for heart failure. Stage B, we have asymptomatic LV dysfunction. Stage C, we have B plus symptoms. D, why do we have the staging? Because now for every stage, we have evidence-based medicine show that if you give medicines or a certain lifestyle change, is going to prevent the evolution for that. So I'm going to propose to you here that maybe we should think about diabetes the same way. Stage 1, we have a lipid profile specific characteristic of diabetic dyslipidemia. Triglyceride HDL ratio is high, check a plasma insulin, higher than 12, fasting, you got a problem. That's stage 1. Stage 2 is the old pre-diabetes stage. Now we have also hemoglobin A1C between 5.7 and 6.4. Why? Because according to the data we have, if somebody is morbid obese with the BMI over 30, we may consider, other than lifestyle changes, adding also a drug that prevents progression to type 2. And then the good old-fashioned type 2 diabetes, I like to call it stage 3. Why is that important? If I'm a patient, instead of telling me, just like we have with chronic kidney disease, we have stage 1, 2, 3, 4, 5. You know, what do you have? Oh, I have stage 3 chronic kidney disease. The creatinine is a little elevated, 1.3. It's like, okay, what's the big deal about it? Well, if I say they have prediabetes, they ignore me. But if I tell them, no, you have actually stage 2 diabetes, time to start working on what you're eating, because that makes a difference. We know that. So I think that's the take-home message here. With Mounjaro is the same, like really semaglutide, except it also has it's a mixed drug with the what we call GAP analog, gastrin inhibitory peptide. What that does works the same like GLP-1 on the central part, but also causes lipolysis. In other words, makes our fat cells to release triglycerides. So from that perspective, theoretically, that's it's more impactful. We do not have an equivalent select trial there from that, but we do have data in diabetics, and it's approved to be treating diabetics with coronary disease. It actually helps. This is a study called SURPASS-3 trial showing that actually improves fatty liver and insulin resistance. And there are actually exciting times that are coming out. We have 4 trials. By the way, there are 100 drugs like this in the pipeline. So we need to know about this because we're going to have different flexibility, different side effects, of course. But here's what I'm excited about. Soon we're going to have equivalent of tirzepatide kind of trial like SELECT trial, but for pre-diabetes. We're going to have results in about a year. Then we're going to have 2 trials, one with Mounjaro and one with Ozempic for diabetics to see prevents coronary progression in diabetes and diabetics. And last but not least, what I'm really excited about, because I always said for 20 years, heart failure with preserved ejection fraction, it's a metabolic disease. It's a diabetic disease. That's why we haven't made any progress in heart failure. And we're going to have actually a trial, tirzepatide for heart failure with preserved ejection fraction, which I'm curious after we lose 20, 30 pounds, whether that's going to make a difference or not. And no, Ozempic or semaglutide is not the ultimate, response. And unfortunately, I wish it would be the ultimate cure. The moment you stop it, 3 months later, are back to the same diabetes and the same weight gain. You gain it back in 3 months. So unless you want to be on it forever, and I guess you could, what side effects we have? Mostly gallbladder-related events. Why? It slows down. It's an inhibitor of cholecystokinin, so it causes gallbladder distension. It also it can cause aspiration pneumonia. So patients who undergo anesthesia, general anesthesia, have to be careful. You gotta stop it for at least 2 weeks before actually they undergo that, because you might need just MP after midnight may not good enough. I'm not talking about the possible healthcare crisis, because it turns out if we really were to give it to everybody who deserves it in this country, it will be about half of all healthcare budget in the country. Don't know if we can afford that. That's for I told you about the risk of aspiration pneumonia. All right, and can we use this together with the lifestyle changes? And I have a confession to make, and we need to pay attention to this. Really, Wendell Berry said that people are fed by the food industry, which pays no attention to health, and then we're treated by the health industry, which pays no attention to food. And the truth is, it's easy to to tell our patients that we have a drug that's going to help us, and it's going to help you, but it's not going to really be the cure of it. And this was on the front page of Economist from last week. Eat, inject, repeat. You know, they are effective. There's no doubt about that. Now, about 20% of patients don't tolerate. I can tell I prescribe them now almost every week for our patients. Sometimes they are approved, sometimes they are not. It's work in progress. But the secret is this, you know, they don't fix the cause. Ultra-processed food is really the cause. So I offer to my patients, I say, look, I'm willing to start you on this, but the first 3 months, I want to see that you change your diet and you cut out the processed food. That's all I'm asking. And then I offer them that. Why? Because if I can cut the ultra-processed food, then I don't run into risk once we stop this, that they reverse back to needing the drug, but also getting back to diabetes. And, you know, also what it's fair, it's wonderful that we have a drug for somebody who's got obesity, but also remember, half of all patients with diabetes and prediabetes in this country are thin outside, fat inside, with a BMI less than 27. All right. As a matter of fact, the highest incidence of type 2 diabetes in this country are people with a BMI less than 25. They are 9-fold to 1 ratio compared to somebody who's morbidly obese. All right. So we're missing the other patients too. And, you know, ultra-processed food is what causes 80% of the problem. And the cause is also 80% of the metabolic problem. So there are two issues. One is the obesity %. The other one is what's happening inside the fatty liver and the insulin resistance. So 20% is genes and stress and sleep, which is important. And, you know, we need to, basically, we know how it means to eat healthy. We just have to do it. That means what's the requirement? Somebody has to cook at home. And that's bottom line. And so basically any diet works. The key is eat the real food. You know, I tell them actually this stuff that it looks, you know, this that they call food, I tell them this is not food. This is some tasty crap that you put in your mouth because out of social habits, convenience, but it's a poison. Our mitochondria do not see this as food. As a matter of fact, it blocks them from function. All right. And you can do all that. If you eat real food, it doesn't matter. You like more vegetarian, you like more, you know, meats, proteins, Mediterranean, keto, it doesn't matter. You can eat anything you want as long as it's made at home from real food. Okay. And that's what I tell them. One is food, and I tell them that's not food. I know we socially accept it. We call it food out of convenience, but it's not. And I know you're not going to believe me, but I'm going to give you an example. It's an anecdotal case, but there are anecdotal cases on things that are extreme, I think make a point. So this is, I have a patient I've known for 20 years in my clinic. That's actually how long I've been practicing as a cardiologist. And I met her when she was in her, in her 20s, and she's 46 now. In December last year, basically she was admitted. He has an EF of 10%. I watched her over 20 years, how she dropped her ejection fraction, pure diabetic cardiomyopathy on 100 units of insulin for the last 20 years. You know, I tried her many times to change, couldn't change anything. Every 2 weeks in the hospital, creatinine now is 2.7. She's extremely obese. We couldn't offer heart transplant, couldn't offer anything but just home Milrinol. So we're about to send her home on Milrinol. And I said, look, I've been begging for a long time. Can you please change your diet? She said, well, what choice do I have now? I said, well, so what do you want me to do? I said, well, it's very simple. Everything put in your mouth, you take a picture. Before you put it in your mouth, you send it to me, and then I clean it up for you. So in 3 days, I clean her breakfast, lunch, and dinner. I show her how to eat. In 3 days, she was off insulin. She was on insulin high intensity since age 17. It took only 3 days. Okay. And all I did, I just show her how I eat. I asked her, well, can you eat like this? This is not hard to make, takes 15 minutes. What about this? Eggs, veggies, avocado. You know, this is a vegetable stew. Those are, all that can be done in less than 20 minutes, 30 minutes. And that's all. I just show her pictures. And I told her, eat like that. And then look what happened. We are a year and 3 months later. No hospital admission for heart failure. Her kidney from almost 3 creatinine, now is 1.4. Her ejection fraction improves from 20 to 25%. She couldn't tolerate any GDMT, and now she tolerates. She's on actually submaximal dose of beta blocker and Entresto Farxiga. And guess what? She lost 70 pounds. She lost actually 7 pounds in 3 months. Her diabetes is being cured. I'm talking about her hemoglobin 1C. It's 5.6 as of today. Okay? And she's so excited. Apparently everybody applauds her because she can fit, I don't know what size she hasn't fit since she was 18, but it's irrelevant. All we did, I just showed her to eat like that, nothing else. Okay, and now she does 10,000 steps so that she couldn't make 20 to the room. I mean, she was every 2 weeks in the hospital. So this tells you, and obviously she doesn't have coronary disease. This is a pure metabolic cardiomyopathy. But if you can do that, and what does it take? First of all, they need to hear from the doctor and from every doctor, not just me. It requires some constant coaching. I tell them you can't be comfortable. You're going to have to cook, or somebody has to cook. You know, you're comfortable today, you're disabled tomorrow. This is, it's perspective how you tell the patient. They say, well, I don't like that, or I don't like that. I say, well, do you like to be alive? Is this a liking situation? No, it's about survival. It's a completely different story. So then a lot of them will change. And when she realized it was a survival, now she's happy. Now she's teaching somebody else from her. And I just tell her no sugar, no white starches, no vegetables, and basically clean up. And anyway, if you guys are interested, you can go to Rescue to Rescue. I have a whole 3 hours lecture what I tell the patient. I think I'm going to stop here because you had enough of me, but I'll be happy to take any questions. Okay. All right.